Good morning, everybody. Thank you so much for attending today's webinar. I am Dr. Anna McCarthy, Chief of Clinical Innovation for Sierra Tucson Group. We're going to be talking about suicide. Just wanted to say to you, obviously this is a deep and painful topic. If this brings up any difficult emotions for you, please just make some extra steps towards self-care this afternoon, because again, this is a deep and painful topic. I'm going to take my camera off so you can see the slides. I welcome any questions. Please just pop them in the questions box, and I'll set aside time at the end of the presentation to make sure that we get to answering all your questions. So I hope you enjoy this presentation. Okay, so we're going to start off. Hold on one moment. Okay, so we're going to start off talking about just some basic terminology, just so we're all on the same page. I'm sure that this is familiar, you're familiar with all of this, but let's define suicide. So suicide is a death caused by self-directed injurious behaviors. Suicide attempts are non-fatal, self-directed injurious behaviors. And suicidal ideation is thinking about or considering or planning to attempt suicide. For all of you in the mental health field, I suspect you deal with a lot of people with suicidal ideation. One of the things we want to be able to assess is intent and the strength of the intent. So is someone saying, if my life doesn't get better by the time I'm 40, I'm going to end my life, and they're 32, there's an intention, but I'm less worried about that than someone saying, you know, I'm going to discharge from Sierra Tucson today and I intend to kill myself this afternoon. So when someone's voicing suicidal ideation, even if it's vague suicidal ideation, we want to be able to talk about and assess the strength of the intent, and then also have they decided on a plan. So how do they intend to end their life? Is it going to be taking pills? Is it going to be jumping off a bridge? Is it going to be hanging themselves or shooting themselves with a gun? So we really want to get a sense of where somebody is at in terms of the seriousness of suicidal ideation, because suicidal ideation really can vary in strength and intensity, from vague and it's probably never going to happen to it's imminent. Okay, so let's look at some statistics from the Center for Disease Control. I shan't read all of these to you because you can read yourself. Something to note, though, is the date. So Center for Disease Control, this data was published in 2019. Obviously, that was pre-pandemic, and we will talk about suicide during the pandemic a little later on in this presentation. So yes, 2019 data. What you can see is that suicide was actually increasing for 10 years prior to the pandemic. It was steadily increasing. Something else we want to look at is that suicide rate was higher in males than females. And the reason why is that actually men tend to use more lethal methods. So women more typically are overdosing with medicines. Men more typically are engaging in things like using a handgun or hanging themselves. So women actually attempt suicide more, men actually complete suicide more. The other thing to look at is that the risk factor for men is age. And so as we're going through this, we're building a profile of who we want to really be mindful of in our mental health practice, who is actually having a clustering of risk factors that we really want to be able to inquire about any suicidal ideation. Okay, so we're going to move on to some contextual risk factors. So this data came from the Center for Disease Control and the National Institute for Mental Health. And so some things that we want to be able to just check out. So previous attempts are certainly predictive of future attempts. So we want to be able to always inquire about if anyone has a history of suicide attempts or suicidal ideation. Certainly mental illness is a risk factor. Social isolation. So again, as we're thinking about, the context in which we exist right now, especially early 2020, we were all very socially isolated because we were trying to stop the transmission of COVID. So checking out, does somebody actually have a meaningful social support system? Criminal problems, so people being released from prison or jail. So again, if you think about social isolation, that's often a factor, along with unemployment, lack of resources, lack of support, being removed from a place where every last decision was made for you to a place where you suddenly have freedom of choice, but without resources to help you along the way. So financial problems, again, I'm tying that back to COVID. If you think about economic crisis that happened when businesses shut down, we can start to see, again, a picture of risk factors. So something else, just I'll let you read again this list, but serious illness, chronic pain, is certainly a risk factor. I say to people all the time, if you're in, daily severe pain, it's very hard to be mentally well, to feel joyful when you're just physiologically suffering so much. And then substance use disorders, obviously, is another risk factor. Okay, so some more risk factors. At Sierra Tucson, we actually ask our clients to complete the Adverse Childhood Experiences Scale. For those of you who may not be familiar with that, Kaiser Permanente in the 1990s basically did a really wide-scale study. They had over 17,000 participants across 25 states in the United States, and they asked them 10 questions about adverse childhood experiences. So things like, did you have a parent who was abusing substances? Did you have a parent who went to prison? Did you grow up in a household where you felt like nobody loved you? So there were 10 questions. The respondees actually just checked a box, yes or no. And they then collected this enormous pool of data, again, over 17,000 participants. It's a huge sample size. So what they really found was that the more adverse childhood experiences somebody had been subjected to, not only the higher risk of mental health issues, which we could probably guess, but higher risk of physiological issues too. So things like stroke, heart disease. If you've not read this study, I highly recommend it. It is fascinating data. For this presentation, I think the take-home point is that adults who endorsed being exposed to 4 or more adverse childhood experiences had a 30-time higher risk of suicide than people who said they had had no adverse childhood experiences. That's really incredible and solid data. And again, something we want to be able to assess. Not that necessarily if we've been subjected to adverse childhood experiences, we're absolutely destined to suicide. But again, as we're looking at these contextual risk factors and personal risk factors, we're sort of tallying them up in our mind to understand who really might be at very high risk, and therefore let's add in more intervention to keep that person safe. So a couple of other things that you can read for yourself, but moving on to some other contextual risk factors. So easy access to lethal means. So we'll talk about that a little bit further, but having access to guns certainly enables fatality of suicide attempts. Some interesting data actually that came from my home country, England, was that the primary means of ending one's life back in the 50s, for example, was actually sticking your head in a gas oven, because typically ovens in England were gas fueled, not electricity. When gas ovens actually were switched over to electric ovens, the rates of suicide went down. So this tells us if we can limit access to lethal means, we're actually going to reduce the rates of suicide. One other thing I want to go back to actually is this idea of cultural and religious beliefs. So in some cultures, suicide can be seen as the noble way out if, for example, you've brought shame on your family. When I presented this last time, I was telling people, if you think about, for example, the samurai, the Japanese samurai, if they had brought shame on themselves, the noble way to exit this world was to actually sort of gut themselves with their sword. And so we want to be able to check in about cultural and religious beliefs about suicide. Also cultural and religious beliefs about mental illness and the expression of mental illness. So we know, for example, in some cultures, discussing mental illness is non-normative. People tend to express mental distress by somatic complaints. So, for example, somebody might say, instead of saying, I'm feeling really, really depressed, they might say, I have a stomach ache. And so we want to get a sense, if we're taking down someone's history and really trying to understand who they are, what are the cultural and religious messages that you grew up with about mental illness, seeking help for mental illness, and about suicide? Okay. Back to this slide. So unsafe media portrayals of suicide. Um, so if we think about, for example, for those of you who are a little bit older, Thelma and Louise, if you remember that film with Susan Sarandon and, oh my gosh, I've forgotten the other lady in the film. But if you think about the last scene of the film, having made their way through the film, the last scene is them driving off a cliff. So we can think about that if we're a little bit older. If we watch something more recently, it might be, for example, 13 Reasons Why, which was a film that was produced by Selena Gomez, basically a young girl who ends up killing herself, and the story is sort of the 13 reasons that led her to suicide. We also have, glorification of people who have ended their lives, like Heath Ledger, Kurt Cobain. And so I think, again, we want to sort of be mindful of what are the messages people are being sent en masse about suicide, as opposed to let's give you resources. That suicidal ideation is not that uncommon. but the end result does not have to be the termination of your life, that we can actually give you resources and help you feel better and build up a life worth living. Okay, so moving on, we're going to talk a little bit, oh gosh, what happened here? Sorry, one moment. Okay, so we're going to talk a little bit about some personal risk factors. So we've talked about some contextual risk factors, right? Cultural beliefs, religious beliefs, lack of support if you're leaving, jail, media portrayals of suicide. But the National Institute of Mental Health actually came up with a list of personal risk factors. So being male, so as I just mentioned, females tend to attempt suicide more frequently, males tend to use more lethal means and therefore complete suicide more frequently. Being older, especially if you're male. So again, if we think about contextual risk factors, it might be being isolated. We know that the elderly actually really experience rates of loneliness at significantly higher rates than any other age group. Lack of connection to community, to family. Being American Indian or Alaskan Native. So I think what this is really speaking to is actually a mediating factor, which is poverty and lack of access to resources to actually get the treatment that people need and deserve. So we'll talk a little bit more about that later on as well. But I think, again, that's really the mediating factor. Being a veteran, so I actually worked for years at the local VA hospital here where I live in California. And, some unique factors are going on right now with veterans. Firstly, they are surviving things that would have killed them in prior wars. So things that would have ended their life on a battlefield in World War II or in Vietnam. People are now getting medical care so that they're surviving. So people have lost limbs or, suffered an IED explosion, actually are living. And so there's a level of physiological distress that perhaps wouldn't have existed because they would have been killed in previous wars. And again, we just talked about that feeling chronic pain is certainly a risk factor for suicide. There also is certainly this fact that veterans have gone on multiple tours of duty. So perhaps thinking they were going to be deployed once, but getting multiple exposures. Something else I learned from veterans as well, if you think back to World War II, there were clear divisions and battle lines. So people wore uniforms, so they were identifiable as the enemy. And there would be a battlefield, certainly in World War I as well. In Iraq and Afghanistan, that didn't exist. So there was no delineated battlefield. There were buried explosive devices. There were no identifiable people in uniforms that could be identified as the enemy. And so veterans would tell me that, they were on a constant state of alert because they didn't know when the next mortar rounds were coming. That led to higher rates of PTSD, and certainly mental illness is a risk factor for suicidal ideation and suicide attempts. Okay, so being a Black child is also a risk factor. Excuse me. Again, I think the mediating factor really here is lack of access to services and also poverty. Not that every Black child that lives in poverty, but certainly we know those are risk factors. In fact, prior to COVID, approximately 20% of children had diagnosable mental health issues. The data told us that less than 5% of those children ever got the mental health services they needed. That's pretty appalling. And if we think about mid-pandemic, our best estimates are that those rates of mental health issues have just about doubled for children and for adults. And again, so few children are getting the services that they need. If you are living below the poverty line, the chances of you actually getting really good quality care is obviously diminished. I think the same is true for people residing in rural areas. So poverty and just lack of capacity to access good quality services. Excuse me, I'm just going to take a sip of water. So another interesting set of risk factors, if we think about education, we typically think that that leads to higher earning potential and therefore better access to mental health care. So we know living in poverty is definitely a risk factor. But interestingly, at the other end of the spectrum, we've got professionals who should be earning a very healthy living. I think seeing police officers on this list is not too surprising, because they're being exposed to things on a daily basis, just like all first responders are, that are sort of beyond the scope of normal human experience. So basically, they go through sort of mini war zones on a daily basis. So I see first responders and their experiences as quite akin to veterans. But think about dentists. So my personal dentist said to me that actually he had lost colleagues to suicide, and that dentists typically are at higher risk of suicide than other professionals. And I asked him why, and he said, I think it's because A, who likes going to the dentist? No. B, in order to be profitable, they have to see so many patients one by one by one, back to back to back throughout the day. It's very, very stressful. So that's sort of an interesting finding, that dentists are not, we don't love going to the dentist, and they have a lot of financial pressures in order to be profitable. Okay, some early warning signs. So again, we've talked about contextual risk factors. We've talked about personal risk factors. Now let's talk about what's going on within a human being. So this data comes from the National Institute of Mental Health. I will again let you read this list. Something that comes up time and time again, though, the big warning factor is the thing that I've put in capital letters, is hopelessness. So, for example, feeling anxiety. It may be a risk factor for suicide, but it's not top of the list. When somebody's telling you that they feel hopeless and they can't see a future for themselves, then I start to get really concerned, because I actually think it is incredibly hard to squash human hopefulness. People have lived in dire circumstances and still held out a glimmer of hope. So hopelessness is certainly a major predictor of suicidal ideation. And we'll talk about actually a measure for hopelessness later on in this presentation. So that's something to really be able to assess with the clients that you're coming in contact with. What are your reasons for living? What are the things that make you want to be here? What are the things that give you a sense of joy or purpose? Who do you feel connected to? And sometimes people's reasons for living is sort of their pet cat. They just couldn't stand the idea of their cat not being, not having their owner around. But it's really important to identify what are your reasons for living, and what is your degree of hopelessness. So some other early warning signs. So planning on the means of death, withdrawing from friends, giving away items. Here, have my favorite earrings, or I'm going to give you my pet dog. I would point out on this list that eating and sleeping more or less, we'll go to the next slide here. That's something that we see showing up with depression. It's not a high risk factor, but it certainly is something we just want to check in about and start evaluating for depression. Something I do want to talk about, though, is a client suddenly reporting feeling dramatically better. So if you're working with a client who is reporting severe depression, maybe they've come to Sierra Tucson to get help for severe depression, they've had difficulty getting out of bed, they're sluggish, they're crying, they have no appetite, no motivation, they can't concentrate. The next day they wake up and they're saying, I feel great, and they're energized, and all of a sudden the depression just seems to have lifted. Be concerned. Depression actually is a tricky illness, and when it's severe, it can be slow to remit. If suddenly someone goes from being severely depressed to suddenly saying, I feel so much better, I think you need to assess about suicidal intent, because people will feel relief when they've made the decision, that's it, I'm going to end my life. All of a sudden, the unbearable emotional pain, there's an end to it. And that in and of itself can make people report feeling better. So we want to have that conversation. If somebody's saying, I'm so much better, I really want to leave treatment, the depression's gone, really investigate suicidal intent. Okay, so some other early warning signs. So wanting to die, talking about wanting to die, excessive guilt and shame. So some of the clients we see at Sierra Tucson may have done things that were so contrary to their value system while they were in the throes of addiction or a manic episode. There can be tremendous guilt and shame. We want to be able to evaluate that. And then the sense of being a burden to others as well. So my family would be better off without me, and I'm just a burden to them. So I can tell you, actually, I worked years and years ago in a Locke psychiatric hospital as I was wending my way through graduate school, and there was a woman who had been hospitalized during a manic episode. She had withdrawn all of the family savings. She'd used drugs. She'd actually ended up prostituting herself to the drug dealer when she blew through the family savings. That she had been barred from being in her family home. And as she emerged from this severe manic episode, the level of guilt and shame was just extraordinary. As her brain almost sobered up, realizing what she had done to herself, but also to her family, was almost unbearable. And so something to actually evaluate with somebody we know who is experiencing bipolar disorder is sort of how they're doing as that mania lifts, because that's actually the time that they're at most of risk of attempting suicide. When I ask this question, people would say, well, with bipolar disorder, probably when they're in a depressed episode, they're most at risk. It's actually not true. It's when people are coming out of manic episodes and they're realizing the reckless behaviors that the mania has made them engage in. It is this guilt and shame. It is this sense of burden. It is this sense of, oh my gosh, what did I just do? That really puts them at risk of attempting suicide. So we want to be able to evaluate that. If you would want a poster about warning signs, you can actually get one free from the National Institute of Health. The link is there. Oops. And then let's talk about, so there was someone by the name of Thomas Joyner. I believe he's at Stanford University. And he said, you know, there are 3 proximal and jointly necessary and sufficient conditions in order for somebody to actually die by suicide. So that perceived sense of being a burden to other people, that could be the person with a chronic pain condition or a disability, and they think that they're just a burden to their family. That sense of not belonging. I've worked with numerous patients over the years that when they're severely depressed, they will talk about feeling like there's a block between them and the rest of the world. So I had one patient, for example, who would tell me, when I get really, really depressed, it feels like a wall of ice creeps up behind me and just wraps itself around me. And I can see everybody else going on with their life, but I can't connect to it. I can't connect to them. I feel like there's this block of ice between me and everybody else. I don't feel like I belong. I don't feel like I fit in. I feel like I'm on the outside looking in. I don't really have a place on this earth amongst other people. So we want to be able to investigate that. And then this capacity to access lethal means. So again, thinking about the research from my home country, you know, when we changed from gas stoves and ovens to electric stoves and ovens, the rates of suicide went down. So thinking about, again, you know, we're more likely to survive taking a handful of pills than we are if we get our hands on a gun or we're attempting to hang ourselves. Okay, so we're going to move on to some research. It's called the Golden Gate Bridge study. The Golden Gate Bridge obviously is close to San Francisco. For those of you that have been there and seen it, you know it's sort of this vast marker on the skyline. It was a place where there were high rates of suicide. And we know that there are places in this country and actually around the world that people tend to cluster to attempt suicide. There's actually research showing that when we block off access, again, we're blocking access to lethal means, rates of suicide go down. So the researchers that completed this study, they said, you know, many people that they interviewed said there was this sense of l'appel du vide, this call of the void. So if you've been to the Golden Gate Bridge, you know it's shrouded in fog most of the time. It's very high up, the water's below you, it's dark and murky. And really this call of the void was this death wish to sort of jump into the darkness and end one's life. They managed to track down 35 people who actually survived. So if we look at this statistic, you know, it's a really lethal means of suicide. Most people would not have survived, but they interviewed people who did. So this to me is fascinating that nearly every single one of these survivors said that the moment they jumped off the bridge, they actually regretted it. They actually said that they really didn't want to die. And interestingly, 90% of them did not end up with their life ending by suicide. So this is such important data. What does this actually mean? It means that people can be chronically suicidal. We know people who have spent 10, 15 years saying, I think about suicide every day. But it also is an event. And if we catch people before they attempt, we can actually intervene and steer them in a completely different direction. Really, my conclusion is that people don't want to end their life. They just can't see any other way out from excruciating emotional pain. And suicide becomes the option that they're thinking of as the only way out from excruciating pain. It's interesting that the Golden Gate Bridge today, not only have they installed very high railings along the side of the bridge, they used to just have sort of a waist-high railing. They now have railings above that, but they also installed nets to catch people. So if they manage to climb over the 10-foot railing and launch themselves off the side, they're actually nets to catch people because of this data that people that threw themselves off the bridge, literally the moment they let go, they were saying, I wish I hadn't done this. So we want to be able to catch people. We can save their lives and turn them around and give them quality of life. So we'll get to how on earth we do that in just a moment. But here's a little visual that I put together to help us sort of think about suicide and this process of suicide. So if you think about a funnel that you pour oil into your car, you know, at the top we've got the general population. We know probably 60% of the general population at some point will have a vague suicidal thought like, you know, I wish I could go to sleep and not wake up, or my family would be better off without me. At the bottom, we've got death by suicide. And in between, we have a whole lot of room to intervene. We'll want to assess those contextual and personal risk factors. We want to assess the intensity of somebody's suicidal thoughts, the chronicity of someone's suicidal thoughts, you know, the degree to which they have intention and the seriousness of their plan to catch them before they attempt, because again, death is a preventable outcome. So moving on to prevention. So we've talked about the risk factors. Now what do we do? This is fascinating data. So for every dollar spent on suicide prevention, we save $2.50 in the cost of suicide. This is extraordinary. This really speaks to the need for sophisticated interventions that really, really work. So what do we do? Prevention is not just about the individual. It really starts at a societal level. So reducing poverty. Poverty obviously is a huge stressor. It also prevents people from getting the mental health treatment that they need in this country. Having secure housing, having health insurance coverage for mental illness. It's something that we battle against in the mental health world is people have health insurance policies, they're mandated to have them now. They get coverage for physical health issues, going to the ER, going to get surgery, but there is not an equivalent for mental health issues. So people get authorized for 6 sessions of therapy to treat 40 years of problems. It's not realistic. Certainly, reducing provider shortages in rural areas and underserved areas. And I actually think this is sort of one of the rainbows of this pandemic. I think pre-pandemic, we thought of telehealth services as really kind of a second tier of treatment. I think with the pandemic, we've really come to understand, and actually the research data supports it, that really there's equivalency between seeing somebody for therapy face-to-face versus doing it via a HIPAA-compliant Zoom platform, for example. So actually giving access to people who geographically are hard to reach or who don't have transportation to get them to a mental health clinic, you know, it can really start to stem the risk of suicide. Okay, some other things. So resiliency programs. You know, I've talked about, you know, in school we learn all sorts of things, some of which we really don't use in adult life. I was terrible at mathematics and learned all sorts of things in trigonometry that I really don't use today. I obviously write bills and pay bills and give tips on, you know, meals at restaurants, but I'm not using those things. But let's think about if we really introduced skill building programs to build mental resiliency, what a difference that would make in our community. Reducing domestic violence and substance abuse, because those are both risk factors. Something else here again, if we're reducing access to lethal means, you know, reducing the quantity of medicines we give people. I think with the opiate crisis we've had in this country, we're starting to get there with opiate prescriptions. So I think people were giving, you know, 90-day supply of opiates to people. I, you know, unfortunately have gone through a couple of major surgeries in the last couple of years, and I know that I discharged from the hospital with a 7-day supply and no refills available. And I think that that is so sensible, so that we're giving people a week supply of medicines that could be fatal, not months and months and months. And that we have, you know, home delivery services and things so people can actually access their medicines easily, but we're not putting fatal doses into people's hands. Okay, so some other issues. Um, let me see here. Sorry, I'm just going to go back 1 second. Yeah, parenting skills actually is something else to be able to bring up. So remembering that ACEs study that Kaiser Permanente did, and looking at the fact that someone who grew up experiencing 4 or more ACEs was 30 times more likely to attempt suicide, it really speaks to the need for parenting skills, parenting support, and family programming. You know, we have to, and this is so cliche, but we have to, you know, take exams and pass a test and get a license to drive a car. Parents, we just presume people know what they're doing. But I know from the research I actually engaged in to do my PhD dissertation that children do not get mental health care if parents are stressed out with a contextual stressors, environmental stressors, their own mental health stresses. Those things are barriers to children actually getting the mental health care that they need. So again, I think we want to support parents, and, you know, support people being effective in their parenting to ultimately decrease the risk of suicide in adulthood. Individually, we want to provide access to the mass of our population. We want them to have really good mental health care, because we know mental illness is such a risk factor. We also want to talk about it directly. So somebody brought up this idea that if we ask someone if they're suicidal, we're actually going to put the idea in their head and then they're going to go ahead and attempt suicide. It's actually not true. We don't have any research supporting the idea that if we ask somebody, we're increasing the risk of suicide. It's in fact the opposite. People who are in excruciating emotional pain want support, they want relief from their pain. So talking about it, you're not going to put the idea in somebody's head and then increase the risk of their attempting it. That simply doesn't bear out in the research we have. Okay. So some measures that we can look at using. So the Beck hopelessness scale. So Aaron Beck was sort of the godfather of cognitive behavioral therapy in this country. You're probably familiar with the Beck depression inventory and the Beck anxiety inventories, but the Beck hopelessness scale is certainly a very helpful measure when we're assessing risk of suicide. The Columbia Suicide Risk Assessment Scale, we use it at Sierra Tucson. It's very commonly used. It's easy to score. We want to be using these assessments. You know, something that stands out here is just, if you look at this data on people who had access to their physician or to a mental health professional prior to attempting suicide, these were missed opportunities to assess how somebody's doing. And that's the question we really want to be asking. You know, how are you doing? How are you feeling? Rather than saying, hey, you look good. It's how are you doing on the inside? How's everything going for you? Especially with ongoing pandemic and all the stresses associated with that, the number of deaths we've had in this country. We're now at a point where most people know somebody who's died from COVID. And so, you know, someone can look great on the outside. It doesn't mean that they're looking good on the inside. So really being able to check in with people and saying, how are you doing? Let me know how life is for you. Some resources here. Again, if you want these slides, as was mentioned at the beginning, you can access them, so you can have these resources, you know, to be able to use. Something I quickly wanted to point out before we wrap is just suicide rates by country across the globe. So I'll let you read here. Lesotho is an enclave. It is its own country, but it's actually situated within South Africa. So it's surrounded by the country of South Africa. Very high rates of suicide. And I've put here just some potential explanations for why this is the case. So for example, Belgium, we know there are high rates of suicide, but actually we think that is because doctor-assisted suicides are permissible and legal in Belgium. And then we have the United States of America. So 16.1 suicides per 100,000 people in 2021. Let's look at the countries with lower rates of suicide. So Haiti, I mean, we think about the earthquakes of recent years, the poverty, the crime, lack of access to resources, and yet look at that number. If we look at somewhere like Nepal, again, very impoverished nation, lack of access to services, again, a much lower suicide rate than us. Same thing if we look at Guatemala, the Philippines, again, lots of issues in the Philippines with crime, with poverty, lack of access to services, very, very low rates of suicide. What do I make of this data? Remember, we talked about that sense of belonging and that sense of being a burden. These countries that have much lower rates typically are collectivistic cultures. So there is a sense of interconnectedness, there's a sense of village, there's a sense of extended family, a real sense of belonging. United States, we're not a collectivistic culture, we're an individualistic culture, sort of every man for himself. You know, what you accomplish on your own. And so that sense of belonging is such a preventative factor when we're looking at suicide. Okay. So just quick summary here. You know, suicide is preventable. You know, the failure to address it is costly to us as a nation. This is really a societal issue. This is not about somebody being selfish. This is about somebody in excruciating emotional pain who can't see any other way out. And yet we want to really address this at a societal level, a community level, addressing individual needs, because we do know that treatment works. Okay, so having said that, I'd love to be able to turn to any questions that we might have. Feel free to put them in your chat box. And I would love to be able to answer any questions. Okay. Okay, so someone had asked, is there any research that telehealth only treatment influences suicide attempts or completions? I've actually not read any data about that. I have read data showing that telehealth is equivalent to in-person therapy sessions. There really are no statistically significant differences. What I would say is with telehealth, so I'm just going to turn on my camera here so you can see me. What I would say with telehealth, we want to be mindful of who we agree to treat via telehealth. Because obviously we're not there if somebody is feeling suicidal. I actually have clients fill in a form giving the address where they will be participating in a telehealth session, so that if they're saying, you know, that they're in a mental health crisis, I know where we can actually send people to get assistance. So I've not read any data, but certainly, like I said, there seems to be an equivalency. Okay, what about reducing access to guns? Yes, again, this is what the research is telling us, that if we reduce access to lethal means, people are less likely to actually succeed in suicide attempts. So certainly, and I know, you know, that can be quite political, but reducing access to lethal means is really, really important if we want to reduce completed suicides. Oh, someone said Gina Davis. Thank you. Yes, that was the other actress in Thelma and Louise, and again, glorifying suicide, driving off a cliff in the car. Yes. Okay, another question. What can we do to prevent teenage suicide? I think this is a really, really important topic. If you think about who was actually impacted the most by this pandemic, I would say it would be teenagers and first-year college students. You know, it's a developmental stage where peers are so important. And what happened is people, or this cohort, was sort of sent home to exist in their bedroom, doing classes via Zoom, not having access to peers. What did they have access to? Social media. And social media probably is a whole other topic we can discuss, but we know that access to social media increases mental health issues, increases eating disorders, especially amongst teenage girls. We're looking at glorified images of people and seeing situations that make us feel less than. So I think one of the things that we want to talk about with reducing teenage suicide is actually a discussion about social media and helping teens and young adults handle the pressures of social media. Those are pressures that I didn't grow up with. You know, bullying via social media, cancel culture, all of those things that were never a part of my teenage experience. So I think that might be a whole other topic, but helping young people really navigate the, you know, the pitfalls of social media. What do you think will happen if the rates of suicide, what are the rates of suicide if the pandemic continues? Well, there's interesting data actually from the American Psychiatric Association. You know, I initially thought because rates of mental illness and addiction and drug use and alcohol use went up, I expected rates of suicide to go up. And remember that slide showing that actually rates of suicide had increased for a 10-year period from 1999 to 2019. Initial data actually said that rates of suicide went down about 2 to 3% in the early months of the pandemic. So why do we think that was? Well, I think initially there was this stance of we're all in this together. We're going to have strategies to try and get through this. This is affecting all of us. You know, we're all in the same, stormy ocean. But that 2 to 3% decrease, I think, is really misleading. It's too big of a blanket statistic. If you look at specific populations, for some people, they were doing well. For other populations, they really were not doing well. So I think our viewpoint shifted from we're all in this together to actually we're not all on the same boat in these stormy waters. Some people are sailing in a luxury yacht and other people have got a rowboat with big holes in it and they're sinking. And that's really what the data shows if we start to look at it in a detailed fashion. So, COVID, pandemic, social isolation, they were not affecting people equally. Not surprisingly, people living in poverty were far more affected by social distancing, economic strife, social isolation. The rates of suicide did not go down for that population at all. So what do I think will happen? I think that the pandemic has accentuated what was going on pre-pandemic, in that people with means were getting access to really good quality healthcare. People with no means were not. People with means was kind of floating through on the luxury yacht in the stormy waters. People with no means were losing jobs, losing homes, losing income, and they were disproportionately affected by the pandemic. So what I think will happen, I think it goes back to those societal factors. We want to support the most vulnerable of us to make sure that they get the mental health treatment that they need. Okay, let me see. Okay, last question before we log off. What do I think about the upcoming plan to use psychedelic drugs for mental illness? There have been studies at very reputable universities. So UCLA, which is just up the road from me here, was doing PTSD treatment using psychedelics under very, very stringent settings and guidelines, and found that certainly it can be helpful in the treatment of mental health issues. This doesn't mean that everybody should go and buy LSD or mushrooms from their local dealer at all. These were very restricted, controlled settings. They knew the purity of the drugs that they were using. Again, there were mental health professionals. This was really a structured and restricted environment. So that might be actually a topic to discuss in a bigger way next time. But yeah, absolutely not. The idea is not that people just go off and buy these things and they have no idea what they're actually ingesting. That is a recipe for disaster. Certainly under controlled settings, we're certainly having data showing that psychedelics can be helpful in treating certain mental health issues. I think that's all we've got time for today. I just want to say thank you so much for participating, and I hope I get to see you at an upcoming webinar. Take care. Bye-bye.